Our next presenter is Dr. Kemi Carter. She's an assistant professor of medicine and assistant dean for admissions at the Pritzker School of Medicine. She's the director of undergraduate medical education for the section of emergency medicine. Dr. Carter's research focuses on studying communication practices in the emergency department in an effort to improve patient care. Many of us know how big and huge this institution has become, and we tend to feel that we lose patients in between the different hospitals. And Dr. Carter's work is to really help with communication from all these different services, and she's going to present some of her initial findings. Kemi?
Thank you. I am Kemi Carter, and I've been working with Dr. Barrett Fromey from the Department of Pediatrics and two of our medical students, Edie Swain and Shirlene Abobi, on this project, physician-patient communication practices during inter-unit transfers from the emergency department, the patient's perspective. So I'll start by giving a little bit of background about what care transitions are. Care transitions refer to the movement of patients between healthcare providers and or settings, generally as the needs of the patient changes. And there are many different types of care transitions. They can occur at the end of a shift between physicians of the same specialty. They can occur between inpatient services, they can occur post-hospitalization or post-discharge, and they can occur in the outpatient setting, maybe when an outpatient physician leaves the institution, or just between outpatient physicians that remain in the institution. And there's been a lot of literature looking at handoffs between providers within the same specialty, and more emerging literature about post-discharge and post-hospitalization care transitions. But one area has received very little attention, and that is the inter-unit care transition. And that refers to patients whose care is transitioned between providers of different specialties and of different units within the hospital. And so the focus of our project was one type of inter-unit care transition. When a patient presents here, or here, so the emergency departments in our institution, and is admitted here or here, the inpatient unit. Now, I mentioned that there is very little literature on this topic, and Hillegas and Cohen actually noted in this article that to date, there have only been about 11 total articles that have even looked at emergency department to inpatient care transitions. And all of those articles, have focused on provider-provider communication, and understandably so. I mean, patients are complex, they require a higher level of care, providers must be focused on transmitting accurate information, and then providers of different specialties are oftentimes focused also on negotiating across medical cultural backgrounds, negotiating across organizational boundaries, as well as sometimes negotiating perceived distributions of power. And so what we know is that the patient experience during these inter-unit care transitions has been largely neglected and not well explored at all. Chad Kessler did survey physicians on their current practices during ED to inpatient care transitions. And not surprisingly, he did find that physicians do believe that it is best to involve the patient and involve the patient's family in these care transitions. But how best to do this has never been described. And as you all probably know, the Joint Commission has put quite a bit of focus on care transitions because we know that communication breakdowns are actually responsible for the majority of adverse outcomes within the hospital to our patients. And so they have published standards that state that we should actually be evaluating these care transitions and the effectiveness of these care transitions. And one of the measures that they have published is actually looking at patient and family satisfaction with the care transition. But again, what specific factors contribute to patient and family satisfaction in the ED to inpatient care transition has never been described. And so this is a vulnerable point in patient care. I said that before, but patients feel vulnerable. They feel sick. And the focus to date in the literature has really been on the provider-provider communication. So what we thought was that, what if we did consider the patient's perspective? What if we did communicate with them in such a way that they prefer and we're communicating the information that they believe that they need? Well, if we do that, then ultimately we hope to encourage a collaborative doctor-patient relationship during the ED to inpatient care transition. And we know that from patient-centered care data, when patients feel like they are a member of the care team, ultimately they can have reduced morbidity, they have a better adherence to medical management, and ultimately they can have improved quality of life, and that is our ultimate goal. Now, the specific goals of our project were to identify the existing communication practices of emergency physicians and admitting physicians, both positive and negative, from the perspective of the patient. And we also wanted the patients to identify what they believe to be ideal or very important communication practices during this inter-unit care transition. And so what we would like to do with this information is actually develop a framework that we can teach to providers to better communicate with the patients during this very vulnerable point in their care. So we conducted a qualitative study. It was a multi-site study. We conducted this study here at the University of Chicago hospitals, the adult hospital and the Comer Pediatric Hospital, as well as North Shore University Health System. And we interviewed about, when I say we, I mean the students, interviewed about close to 70 patients. We did semi-structured interviews of patients and the caregivers of pediatric patients who were undergoing transfer from the emergency department to an inpatient unit. And our one exclusion criteria was patients who were admitted to the ICU setting. So we did not include those patients. And so as patients described the communication practices, both positive and negative, of their emergency and admitting physicians, and also those communication practices that they believed to be important or ideal, 4 specific themes emerged, and they were explanation, bedside manner, information research and review, and teamwork. And as you can see, there are specific communication practices or sub-themes that emerged that fell under each one of these 4 themes. And I'll discuss the more common sub-themes or more common communication practices that our patients did mention. So when asked about those communication practices that they believe were positive, so these were positive experiences for the patient, for both the emergency physician and their admitting physician, they appreciated or viewed it positively when they explained the plan of care, when they ensured patient comprehension, and when the patient actually felt confident in the provider and in the care that they were receiving. For the emergency physician, they appreciated or viewed positively when the emergency physician discussed the ongoing problems with them and made sure they reviewed that with them. They provided a clear reason for admission and had a reassuring presence. And for the admitting physicians, they appreciated it when they specifically asked the patient what their concerns were throughout this transition and paid attention to those concerns. Those practices or sub-themes that emerged commonly that were viewed as negative by provider for both emergency and admitting physicians, it was viewed negatively when they did not pay attention to the patient's concerns. I think sometimes we have in our mind what the patient needs and we don't specifically ask the patient what they're concerned about. So this actually emerged as a very common negative theme. When there was a lack of physician presence, not only physical presence, but when the physician did not let the patient know how they could get in touch with them should they need them. That was important to the patient. When they failed to instill confidence in the care that they were receiving and in the team. And then when there was role confusion or lack of a clear introduction, patients seemed to get confused, especially in the academic institution, of what provider was serving what role on what team. For emergency physicians, it was viewed as negative when we did not provide a plan of care and failed to ensure patient comprehension. And for the admitting physician, when they did not discuss problems and they failed to provide a timing or sequence of events that the patient could expect. And then patients described what they believed to be ideal or those important communication practices of their providers. For both, they wanted their physicians to explain the plan of care, the timing and sequence of events. They wanted both providers to provide an update on status and ensure patient comprehension. And again, for the emergency physician, it was very important for them to discuss the ongoing problems, have a reassuring presence, and explain the reason for admission. And for the admitting physician, patients thought it was important for them to be transparent, to be present throughout this transition, or to let the patient know how to get in touch with them. When they were paying attention to the patient's concerns, that's very important, and explanation of the clinical course. And I should mention here that for the admitting physician in particular, plan of care was overwhelmingly the most positive or the most important theme or sub-theme to emerge. It was very clear that patients over anything else wanted their admitting physician to explain the plan of care. Whereas for the emergency physician, all of these themes emerged commonly but with similar frequency. And so it seemed as though the patients were placing equal importance on these sub-themes that emerged for the emergency physicians. So in conclusion, explanation emerged certainly as the most common theme when patients describe those positive and important communication practices. And so patients certainly value when all aspects of their care are explained during this care transition. But bedside manner emerged as the most common negative theme when patients considered their experience, suggesting then that a lot of the things that we do, our body language and the way we communicate really serve as barriers to an effective doctor-patient relationship during this transition. There was overlap in the communication practices of both the emergency and admitting physician, yet the expectations for both of those physicians did differ. And so I mentioned that for the admitting physician, it was very important for them to explain the plan of care clearly, whereas the emergency physician was expected to do several things that I mentioned in the last slide. So for future directions, Dr. Amber Pinkavage and her colleagues did this qualitative study that actually looked at patient perspectives when their resident physician graduated from the program and their care was transitioned to another resident physician. And so we've been working together to actually develop this framework and develop teaching tools that we can use to teach faculty and teach residents and teach medical students how best to communicate with their patients during care transitions. And so we did create this video. That's Dr. Pinkavage in this video as the patient, and that's Edie Swain as the doctor. And so we created this and produced this video that actually illustrated those positive and important and some of the negative communication practices, and we use that as a start to our discussion. And then Amber and I have preliminarily put together this transition framework that we will make into a little pocket card that we can use also as a teaching tool. And it sort of lays out what the referring or emergency physician would communicate. That would be the top part in green, and what the admitting or accepting physician would communicate to the patient, and that is that bottom part in gray. Again, I'd like to thank the Bucksbaum Institute and our research assistants, Maha Ahmad and Milky Vu, and I'm happy to take any questions.
Any questions?
You know, we are continuing to evaluate some of the data that we have. And it's interesting, you know, this idea of confidence, the patient feeling confident during this period of vulnerability in the care team was very interesting to me. And so we're going through and trying to really figure out what was it that made the patients feel confident in their care team. And it was really, so far, it's been really two things. One is that the physicians make it clear to the patient that they have reviewed their medical information and come in with some foreknowledge of the patient. And the second thing was that the physicians clearly state that they have spoken to each other. Those two things actually make the patient feel more confident in the care team and in the care that they're receiving. So I thought that was interesting. Shared decision making, I actually thought would emerge as a more common theme, and it didn't actually compared to the other ones that I described. So that was surprising to me as well. Yes. Thanks.
Dr. Koshy specializes in the treatment of brain tumors and lung cancer. His research involves examining the comparative effectiveness of different radiation strategies and interventions in patients with lung cancer and how disparities within these populations affect subsequent therapies and outcomes. He's going to discuss the frequency and factors that result in overtreatment of patients requiring palliative thoracic radiotherapy and metastatic lung cancer. Matt?
All right, thank you. So today we'll be talking a little bit about thoracic radiation for metastatic lung cancer. And I'd like to start off with just a little bit of background information. So palliative chest radiation plays an important role in patients with stage 4 lung cancer. Almost 40 to 60% of these patients will require palliative radiation because their primary tumor often causes symptoms such as cough, hemoptysis, or chest pain. And so radiation is very effective at treating these symptoms. Here you can see a patient with a primary lung tumor, and then 3 anterior beams and a posterior beam treating that. So the goals of any palliative regimen include that we provide adequate symptom relief and control of the tumor, while at the same time minimizing side effects and the duration of treatment which is especially important because this patient population has a limited life expectancy. A quick background slide on how radiation therapy is delivered. So it's usually delivered in a series of treatments or fractions. Patients come back and forth to the clinic. They lie flat on the table. The machine rotates around them, and they get their treatment. So we optimize the fractionation schedule for individual circumstances. And things we look at are the total dose that's delivered. We look at the dose per fraction and the total treatment time. So 2 examples of common palliative chest radiation doses. One is 50 gray in 25 fractions, given over 5 weeks. That would give 2 gray per day. Another very common regimen is 30 gray in 10 fractions, given over 2 weeks. That would give 3 gray per day. So how do we know what regimen to use? So we do randomized trials. And for palliative chest radiation, there's actually been quite a bit of study to look at what's the optimal chest radiation dose. There's been 14 randomized studies, and none have shown a significant benefit to giving prolonged courses of radiation, which would be defined as greater than 15 fractions. There's also been a Cochrane meta-analysis, which also came to the same conclusions. And in response to all this data, the American College of Radiology, the ASTRO, the American Society of Radiation Oncology, and the NCCN all have treatment recommendations, which all state very specifically that patients should not get more than 15 fractions of radiation when it's given with palliative intent, specifically for lung cancer. So the purpose of this study was to characterize national practice patterns of care for patients who are getting palliative chest radiation. We were going to assess the prevalence of long-course treatment, which is a regimen that's not associated with any type of high-level evidence. So to do this study, we utilized the National Cancer Database. This is a large database that includes 76% of cancers that are diagnosed in the United States. It collects information from Commission on Cancer accredited facilities. The COC is a joint project between the American Cancer Society and the American College of Surgeons. And so it's one of the largest registries in the world, and they have specific criteria in place to make sure that the data meets certain quality benchmarks. So our inclusion criteria, the entire database for lung cancer included over 1 million patients. We looked at patients who were diagnosed between 2004 to 2012, who got 1 to 40 fractions, and our final cohort included 46,800 patients, which makes us one of the largest analyses to look at palliative chest radiation. And so our results, very simply, the first thing we looked at is who got an evidence-based treatment regimen and who didn't. And so we were very surprised to see that only 50% of patients were treated with the 1 to 15 fractions of radiation. The other half were treated with greater than 15 fractions. The median days on treatment for the patients who got an evidence-based treatment regimen was 16 days versus 44 days if you didn't get an evidence-based treatment regimen. So that was significantly prolonging patients' treatment courses. So the next thing, we stratified it more by looking at the number of radiation fractions delivered. And it wasn't just that they were getting 16 to 20 fractions. Almost 28% were receiving greater than 25 fractions. The next thing we looked at was to figure out, so why are patients getting longer courses of radiation, which is not recommended? We looked at clinical factors like T-stage and size of tumor and nodal stage and maybe the age of the patients. None of those really predicted for who was getting longer courses of treatment and who was getting shorter courses of treatment. So then we started looking, one of the things we looked at was insurance status. So you can see here the blue are the patients who are not uninsured patients, green is Medicaid, purple is Medicare, and then red is the patients with private insurance. So you can see the patients with Medicaid and who are uninsured had a higher likelihood of getting 1 to 10 fractions. If you had private insurance, which is the red bar, that increased the likelihood that you were going to get treated with a longer course of treatment. The other factor that strongly predicted for what type of radiation course you were going to get was the facility type. So there were the treatments, patients are classified in what facility type they get treated at. Community cancer programs, comprehensive community cancer programs, or academic research programs. Ideally, you want all patients to be treated with a higher dose per day because then the patients are treated in a shorter fashion. But you can see here patients treated at a community cancer program had a higher likelihood of being treated with a lower dose, versus if you got treated at an academic research program, you had a higher likelihood of being treated with a higher dose. So the reason for this, we think, is there's a lot of financial pressures, and radiation is reimbursed per fraction. It's not reimbursed per episode of care. So there may be pressures that are causing centers to prolong courses of treatment. The next thing we do is a logistic regression looking at the likelihood of receiving greater than 15 fractions of radiation. We included everything in the model: gender, comorbidities, age, histology, size of the tumor, race, facility type, insurance status, volume, year of diagnosis, a number of variables. The two strongest predictors for likelihood of getting more than 15 fractions of radiation was if you had private insurance, so that increased your likelihood by 40%, which was highly statistically significant. Or if you were treated in a community cancer program, that increased your likelihood by almost 50%, which was also highly statistically significant. So our conclusions from the study were that nearly 50% of patients who received a long course of radiation that's not consistent with the results of published phase 3 studies, and that these intensive treatments are associated with a higher risk of morbidity without any meaningful clinical gain. So we published the results a couple of months ago in Journal of National Cancer Institute. It got a lot of media attention. And what we wrote about was that the way to solve this really is that more work is necessary to educate clinicians on the proper delivery of palliative lung radiation. In response to our publication, ASTRO, the Professional Society for Radiation Oncology, said that they would update their guidelines to incorporate these results to include that. We also think more research is necessary to understand why patients who are treated at these community sites and with private insurance are more likely to receive longer courses. And that may be due to the reimbursement model, and that which may need to be changed. And then also, very importantly, early involvement with palliative care specialists can improve outcomes and adherence to evidence-based treatment choices. Yeah, so thank you. I'd like to thank my collaborators and obviously the Bucksbaum Institute for their support of this work. Thanks. Any questions? We looked at geography by four regions, northwest, south, and then it didn't make a major difference.
Now, I wonder whether your data permitted you to verify the absence of benefit from the higher dose radiation.
Yeah, so there is survival information associated with the data. Fortunately, you get sort of a bias because physicians may be more likely to overtreat patients with better performance status. So it was difficult to look at outcomes, unfortunately, with this data set, specifically in the palliative care population. But that would be the next step, is to show that, unfortunately, none of the evidence really suggests that there is any survival benefit or difference in palliation when you use the higher doses, at least on the randomized studies. Thanks.
Presentation is by Dr. Manish Sharma, who's an assistant professor in hematology oncology. Dr. Sharma's work focuses on the development of novel therapies for patients with cancer. The broad objective of his research is to improve the development and use of anti-cancer therapies by improving doctor-patient communication with respect to informed consent, especially in phase 1 clinical cancer trials. His talk today will discuss informed consent communication, how it can be improved between oncology physicians and advanced cancer patients in these trials. Manish?
Thank you.
Good afternoon. I want to thank Dr. Siegler and colleagues for inviting me to talk today about our project on informed consent communication for phase 1 trials in advanced cancer patients. Phase 1 cancer clinical trials are generally enrolling patients with advanced incurable cancer that's refractory to standard therapies. They have a life expectancy of more than 3 months in the opinion of their treating physician, and generally good functional status. So these are patients who can do, for example, light housework or office work. They may have mild restrictions in their functional status, but are not severely restricted. The purpose of phase 1 cancer clinical trials is generally to establish the safety and tolerability of a new drug or a combination of drugs. These drugs are oftentimes being used for the first time in humans. And one of the major goals is to really determine the best dose of that drug or combination to carry forward in subsequent trials. So oftentimes they use something called an escalation design, where the initial patients get a low dose of the drug, and then subsequent cohorts of patients get higher and higher doses until you run into either toxicity or you run into sort of the ceiling that was pre-specified. We are often looking at how much drug is in the blood at various time points, what we call pharmacokinetics. But one really important point is that phase 1 clinical trials in cancer are generally not about establishing anti-cancer efficacy of these drugs. That is something that is more established in phase 2 and or phase 3. The elements of informed consent are the same whether you're talking about cancer patients or non-cancer patients, and these are very well established, I think, in the ethics literature, certainly. When it comes to phase 1 clinical trials, I think you do need to have a basic understanding of prognosis, especially the fact that the cancer is incurable. The purpose of the study, of course, procedures and drugs involved, potential risks and benefits. It's important that patients know that they can abstain from the study and still receive care with that same physician, and that they can withdraw from the study at any point in time and for any reason. It's important to establish the alternatives to study participation, including for phase 1 trials, other clinical trials besides maybe the 1 or 2 that are being discussed at a certain visit, no treatment at all, and then certainly any form of symptom management, which we oftentimes refer to as supportive care, comfort care, palliative care, and certainly hospice. This topic has been of interest at the University of Chicago for many years, and this study goes back a few decades to 1995, which is incidentally the year I graduated high school. But you'll recognize on here some of the key players: Dr. Doherty, Dr. Rattain, Dr. Siegler was the senior author on this study, and this was published in the JCO. This was a survey study conducted back in the 90s, looking at patients as well as their oncologists, and the conclusions were that cancer patients who participate in phase 1 trials are strongly motivated by the hope of therapeutic benefit, that altruism is much more minor of a component contributing to their participation, and that only a minority of patients appear to have an adequate understanding of the purpose of phase 1 trials as being dose escalation or dose determination studies. So there is a communication gap, a problem here. Subsequent studies have been done both by other groups as well as by our group here at the University of Chicago. Faye Hubaki and colleagues performed this study called the RIA study, where they looked at audio recordings of encounters between physicians and patients consenting for phase 1 trials. They analyzed these recordings using the rotor interaction analysis system. And one of the interesting findings, among others, was that fellows who were part of these encounters contributed only a small percentage, 23% of the dialogue on average. And they contributed less when the attending was present, maybe not surprisingly. And the majority of what they talked about was really just gathering biomedical and psychosocial information from patients. So we felt that, looking at that study and the conclusions from that there was an opportunity to empower fellows to discuss informed consent elements for phase 1 trials. So that led to the context in which we launched this trial called P1 Real, a pilot study of improving phase 1 informed consent communication in real-time clinical encounters. And this was supported by a Bucksbaum pilot grant. The objectives of the study were to describe the verbal and nonverbal communication skills of first-year hematology oncology fellows regarding informed consent elements, to describe the patient's understanding of these elements, and to explore associations between what the fellow was communicating and what the patients were understanding, with the hypothesis, of course, that there would be strong associations uncovered. Our methods were, the subjects were the first-year fellows as well as the patients. The fellows underwent a curriculum that involved our Fellow Talk Communication Skills series, which is all about doctor-patient communication, a topic that I think Olwen Han has covered in prior sessions here at Bucksbaum. And this included a dedicated session on informed consent for phase 1 trials that I taught at the beginning of the academic year. Then they had a chance to observe attending level discussions regarding informed consent for phase 1 trials. This is in our dedicated phase 1 clinic on Wednesday afternoons. And then they had opportunities to lead these discussions with real-time feedback provided by their attendings. We video recorded the fellow patient encounters and analyzed these videos with a validated software called CanCode. Patients and caregivers also completed post-encounter surveys that included elements of prognosis, how well they understood the informed consent elements, and perceptions of the fellow's communication skills. This is a screenshot that is basically a reminder for me to show you a video here. So the video is just to kind of give you a snapshot of what we were doing, but we videotaped these encounters. This is a screenshot of it, but fellow sitting with the patient, and then later on the CanCode software would analyze that and pull out elements, and I'll show you examples of what it pulls out. So the demographics of our research subjects, there were 98 clinical encounters that have been analyzed to date. The average length of the encounters was 47 minutes. These involved 13 first-year hematology-oncology fellows, so essentially 2 academic years of first-year fellows with the distribution here, pretty diverse group of fellows. The 98 patients had, I would say, characteristics that were pretty typical of our phase 1 clinic, as shown there. And then in terms of what we found as far as the fellows' verbal skills, so regarding elements of prognosis, many fellows addressed prognosis in a qualitative manner, but also many of them used terms such as incurable or terminal. Very few of them used what we call a quantitative or life expectancy approach, giving an actual number to patients. Regarding the purpose of the study, I thought our fellows did quite well. They, addressed a lot of issues relating to dosage, side effects, dose escalation, or tolerability. These are all relevant descriptions of what a phase 1 trial is about, and notably absent from here is efficacy or how well the drug actually works. So I was happy to see that. As far as potential risks and benefits, as far as risks go, fellows tended to stick to more general terms. These drugs could make you sick, but tended to shy away from using specific terms such as nausea, diarrhea, what specifically might happen. They did only in a minority of cases talk about these risks being life-threatening. I'd like to see room for improvement in that. And then as far as potential benefits, they did well in terms of talking about specific benefits that patients might have as far as disease stabilization, tumor shrinkage, or improved quality of life. The remainder, sticking to more general terms like you might do better. As far as alternatives to phase 1 trials, many fellows use terms such as supportive care or palliative care. Some of them talked about other clinical trials. We could certainly see this number go up. And a few others talked about refusing treatment or doing no treatment. Interestingly, absent from here, none of our fellows used terms such as hospice or comfort care, despite, I know because I gave the lecture talking about those potential terms as alternatives to phase 1 trials when I teach them about it. As far as fellow nonverbal skills, they did very well, as you can see, in terms of using very good communication skills, facial expressions, posture, facing the patient, using appropriate speech in terms of activity and tone. The only one that was a minority of encounters was appropriately touching the patient, and that's understandably maybe something that some providers may not feel comfortable doing. As far as what the patients ended up taking away from the encounter, as far as their understanding of prognosis, we asked patients, had they ever discussed a prognosis with their doctor in terms of life expectancy at any point during their illness? So this could have actually been their previous oncologist as well as the fellow that they were seeing that day. And the majority said yes, but still a very, very significant minority said no. And if they had discussed prognosis, we asked, what did they tell you? And most of them had been told qualitative information rather than quantitative or time as far as life expectancy. As far as their understanding of the informed consent elements, as far as purpose of the study, they actually did pretty well, most of them identifying either safety, dosage, or side effects as the main purposes of the study. So this was a little bit of an improvement from what we saw in the 1995 paper. But still about 15% of them felt that one of the purposes was, does the drug work? And that's actually a gap because that's not something that the fellows had stated in our video analysis. So as far as potential risks and benefits, about 9% of them felt that there were major risks involved with the study, and about 42% felt that the trial would provide some kind of medical benefit or gain in quality of life. Again, maybe reflecting the fact that there's this therapeutic misconception that they think that the trial is going to benefit them directly, even if we're not promising that. As far as alternatives to study participation, a good majority did identify palliative care as an alternative, but only a minority described other trials as being an alternative. We found some interesting associations between fellow statements and then the patient's understanding of informed consent elements. So one that we found, I think, that I was really surprised by was that empathic statements by fellows such as, I understand what you are going through, were linked to patients subsequently recalling the purpose of the trial as being dose determining. So patients actually walked away with a better understanding of what the phase 1 trial was about when a fellow made an empathic statement, and this was, strongly significant statistically. Also, optimistic or reassuring statements like "it will be okay" were linked to patients subsequently recalling the purpose of the trial as safety, which is certainly good. Partnership statements like "we will work together," these can kind of cut both ways. I think, as most of us know, we want to be seen as aligning ourselves with our patients, but that can also sometimes mislead them. And in this case, partnership statements were linked to patients recalling the purpose of the trial as providing medical benefits or gains in quality of life. So maybe giving them a little bit of a wrong impression as to what the phase 1 trial is really about. So in conclusion, we were able to develop a pilot program to educate fellows regarding informed consent communication for phase 1 trials. This was successfully implemented in our clinic. We have a lot of rich data from video recordings of these encounters that can help to identify communication strengths and weaknesses. But there are still gaps between fellow communication and patient understanding of informed consent elements. I would highlight purpose of the study as being one of those. And there are significant associations, interesting ones, I think, between fellow statements and what patients understand about informed consent elements. So lots of, I think, interesting avenues that we could take this research in the future. I want to acknowledge my co-investigators and especially embarrass and point out Faye Hubaki, without whom this work would really not have been possible. She was the one who was holding the iPhone camera in the clinic, actually taking these videos, as well as doing the CAN code analysis and the post-encounter surveys with patients. So really want to thank her for her support. Also my colleague attending physicians who allowed us to do this videotaping during their clinic visits and also provided feedback to fellows on their attempted communications. And then all of our oncology fellows, 13 of them that were willing participants in this study. Special thanks to the patients and families who allowed us to do this, and to Dr. Siegler and the Bucksbaum Institute for the support and the pilot grant. Thank you. Happy to take any questions. It's in the informed consent document, which all of these patients do sign when they go into these clinical trials. And then the opportunity is there verbally to discuss that. And it's oftentimes there twice. Once with the fellow, when the fellow is going in the room and doing their visit with the patient. And then when they come back with the attending physician, right, to finish up the visit. So, between the attending, the fellow and the attending, I have no doubt that it was, made, certainly in the times when I was the attending physician, I certainly made a point of making it clear that the purpose of phase 1 trials are safety, tolerability, learning about the drug, and not about, treating their cancer. That's right. That's what I typically say. I can't speak for my other attending physician colleagues. We could go back to the video, obviously, and uncover that. But, certainly that's part of my usual parlance, my usual conversation with the patient. And fellows, I think, were variable in terms of how they expressed that, as you saw. But actually, in that pie chart of what they said about purpose of the phase 1 trial, there was no slice for, this drug working or efficacy of the drug. So fellows were generally not claiming that phase 1 trials were about how well the drug works. But yet, nonetheless, patients sometimes walked away with that impression, maybe because that was a preformed impression that they had, or maybe their community oncologist told them that we should send you to the University of Chicago because maybe they've got something for you that's going to work for your cancer. And it's not unheard of for patients to derive benefit from phase 1 trial drugs in phase 1 trials, but the rates we know are extremely low. And so it's certainly not an expectation that we want patients to have when they're going through the informed consent process. Other questions?
For what is one of my favorite times of the symposium, one of our student scholar presentations. Claire Smith is a second-year Pritzker medical student. She's researched communication during awake surgery under the mentorship of Dr. Alexander Langerman and Dr. Nancy Schindler. Claire graduated summa cum laude from the University of Michigan. She worked with Dr. Alex Langerman. As many of you may recall, he was one of the first 2 junior faculty scholars appointed by the Bucksbaum Institute in 2011. He has now moved to Vanderbilt University, where he is spreading a lot of the Bucksbaum knowledge to Vanderbilt that he learned here. But we're really fortunate to have Claire talk about some of her research. She'll discuss her research on communication between surgeons and trainees during awake surgical procedures. Claire?
Hi. Thank you so much to the Bucksbaum Institute for supporting this research and for inviting me to talk today. As Dr. Sorrentino mentioned, I'll be discussing intraoperative surgeon-trainee communication during awake surgery, with an awake patient, excuse me. So when many people think of awake surgery, I think images like this come to mind, the very exciting awake craniotomy with the patient playing the guitar, the violin for real-time monitoring. But increasingly, awake surgery looks more like this. It's a very cost-effective, convenient way for patients to have outpatient procedures done. And for those reasons, it's becoming increasingly common. But patients still report mixed perspectives on undergoing awake procedures. And as of yet, no qualitative description of surgeon-patient communication in this context exists. So to this end, we hoped to qualitatively understand how surgeons communicate during awake procedures, what they view as the advantages and disadvantages of awake procedures, and how they teach and learn communication in this context. And to that end, we undertook qualitative research. We identified attending surgeons at North Shore and the University of Chicago who perform a high volume of awake surgeries, over 30 per year, and recruited them by email for in-person interviews. We eventually interviewed 23 surgeons. I try to translate that to the patient so she understands what we're talking about. Other surgeons described warning the patient that the teaching conversation was about to occur. I'm telling the patient, I'm going to be saying some things that you may not understand. We're talking about the actual logistics of the procedure, the details, but I'll explain anything that you want me to explain to you. And with regards to excluding the patient, some surgeons described using word choice to keep the patient out of that teaching conversation. I try to avoid any use of words that involve knife, sharp, needle, and replace it with entry instrument. We keep coming up with different euphemisms. Surgeons also described using jargon. We try to use our OR words, quote unquote, so we make sure to use anatomic language as opposed to colloquial terms. Surgeons describe teaching quietly. I talk in two different voices. I talk in the loud voice of God kind of a sound when I'm talking to the patient, and I'm muttering under my breath when I'm talking to the staff, to the resident with me, particularly if the resident is doing the surgery. Surgeons also described using nonverbal communication. I would definitely be more explicit in telling them how to do it and what they shouldn't do or what they didn't do right if the patient was not awake, but I use a lot of sign language because they are. And surgeons also describe teaching beforehand or afterwards outside the room. I try to do as much teaching about what's going to happen in procedural things before going into the room, just because for a patient to be hearing you explain how to do, like, push here on this button, they lose faith that the person who's doing the procedure knows what they're doing. And as I mentioned, many surgeons also brought up managing trainee involvement as a challenge that is unique in this context. And they had really varied approaches to it. From consent, I'll actually always ask the patient if it's okay if the resident does it, to deception. So during awake surgery, there are times I'm not actually scrubbed. I have the trainees doing it themselves, but I talk and ask for the instruments to make it sound like I'm doing the surgery to the patients who are awake. And attending surgeons also described how patients' healthcare literacy played into their approach to managing trainee involvement during awake surgery. You want to rule out those people that are husbands or wives of surgeons because they're generally pretty savvy and they don't want to be operated on by a resident, with rare exceptions. So I figure those I have to ask, so I just ask everybody. And other attending surgeons described using a team approach to managing trainee involvement and also described some of the challenges therein. If the patient can see, you cannot say we're going to be pushing on the tissue for a little bit because we is a collective. If the resident is the one holding the needle, then you can't really say we're going to be doing this when they know full well it's the other person doing it. So to conclude, surgeons described communicating with trainees during awake surgery in ways that include the patient in the teaching conversation, either translating that teaching to the patient or warning them about its occurrence. They also described techniques that exclude the patient from the teaching conversation, using word choice, jargon, or euphemism, teaching quietly, teaching beforehand or afterwards outside the room, and using nonverbal teaching. And surgeons also described challenges in managing trainee involvement during awake surgery, from informing and consenting patients all the way to deceiving patients, and also using a team approach. And surgeons described some of the challenges with using a team approach in this context. There's some limitations to this research I want to mention. It's a small selection of willing surgeons in similar practice settings, and some specialties were more represented than others. Additionally, I think it bears noting that surgeons discussed patients under a variety of anesthesia, from no sedation to conscious sedation, and certainly the amount of sedation that patients had on board impacted the way the surgeons communicate with those patients in their practice. So moving forward, this research certainly brought up some questions for us. How do patients perceive this exclusion versus inclusion? We we know that we're not trying to make a value judgment about it one way or the other, but we're still not sure how patients feel. Are they glad to be left out of the conversation, or do they wish that they could be a little bit more involved? Why do surgeons hide their teaching? Who are they protecting in doing this, and from what? Are they trying to protect themselves from liability, their residents from moral angst, or the patient from what they see as unnecessary anxiety? Moving forward, we've undertaken interviews with patients who've undergone awake surgery. We've interviewed 40 patients and are working towards a curriculum that hopefully susses out some of the agreement between patients and attending surgeons on what best practices in this context for communication might be. And specifically, we're interested in helping surgeons feel comfortable with some of these difficult conversations about discussing and managing trainee involvement, something unexpected that came up during our research. And with that, I'd like to thank the Bucksbaum Institute for Clinical Excellence for sponsoring this research. Thank my co-authors, Dr. Christy Geaton, Joe Preeser, Dr. Mark Siegler, Dr. Nancy Schindler, and Dr. Lingerman, Dr. Peter Angelos, and also thank the Pritzker School of Medicine Summer Research Program for their additional support, as well as all of the participating surgeons. Yeah, I agree. I was alarmed too. I can say that wasn't common. I picked out for this presentation sort of either end of the spectrum. The surgeon who says, I talk with every patient. I say, here's the resident, here's the parts they'll be doing. And I picked the surgeon who was very candid and said, I will deceive patients. I don't know that I can say what specialty it's in, just because we have to really keep things shrouded in anonymity. But I will tell you that by and large, people were somewhere in the middle and acknowledged the challenges of having to be somewhere in the middle and not really knowing a clear way forward with that conversation.
So thank you. As we learn about these different practices, to come up with curriculum, which we then hope to not only use here to teach our students, residents, and faculty, but we hope to then disseminate, to other institutions as well. It's one of the things we talked about in our meeting this morning, that we should be able to develop ways of protocolizing this information, this work, and teaching in the future. And we hope we're going to have products in the future that the Bucksbaum Institute will spread to other institutions as well. What we'd like to do is have our trustees, our board, come up to the front, and maybe we can ask them to give some comments on how we're doing as the Bucksbaum Institute, Dr. Rubenstein and Dr. Roberts, to come up to the front. And
thank you for just a wonderful, rich afternoon. And Kay and Mark, I hope you're very, very proud of all that's been accomplished with your life effort and resources and generosity. It's been phenomenal. So I actually have a number of comments, and I wanted to start with Arthur's really beautiful, thought-provoking presentation on women in leadership in academic medicine. And first I want to say that if you think that was offensive, you need to work on it, get a little better at that being offensive thing, because I don't think anyone was offended by your very, very thoughtful comments. I just wanted to start with a little bit of a personal perspective. I think I must have oppositional defiant traits, because I remember in medical school people telling me you can't go into ethics and ever really have a career in that. I remember them saying you can't be a woman and have roles of power in medicine. I remember them telling me you can't go into psychiatry if you ever want to be taken seriously. You certainly can't go to New Mexico and have a great career. In fact, I remember someone telling me at University of Chicago, you'll wither on the vine with the path that you've plotted out doing psychiatry and ethics. And I'm here to tell you, I am not withering. But I think it really speaks to some of the unconscious bias and the conforming pressures that women in medicine experience. At that time, in my medical school class here at the University of Chicago, we weren't quite at parity, but there really were quite a number of medical students who were women in our class. But I do think that throughout my entire career, I have had the experience of bias and harassment. I remember when I was pregnant with my first child in medical school, one of my classmates said, I thought you were going to be a good doctor. That was the comment to my joyful news. I remember in residency, people thought I was a pharma rep. They didn't think I was like a trainee, a doctor in training. Just 3 weeks ago, in a high-stakes meeting, I was asked by someone for some coffee. When it's true. I was on the National Advisory Board for the National Institute of General Medical Sciences, and when I was first introduced, I was pretty young, and I was a chairman early in my career. And when I was introduced, the person stumbled on my introduction and said, "Oh, you probably have an endowed chair. You must have an endowed chair. You're not a chairman." And then went on to introduce me, and I was a chairman. And to this day, I refer to myself as a chairman of my department for that reason. And recently, I was told by someone, "I thought you would be taller." So it's alive and well. But what I've come to appreciate is that in medicine, and as a psychiatrist, I think about transferences, and you're often thought of as more like a daughter or a mother, a wife, maybe even a lover. There's not a social role for a woman in power other than in these roles. And occasionally you're a sister, and that's kind of how people feel about you. But it is an important part of your life. You end up having to actively manage that. And I wish it were not the case, especially as the mother of many daughters. I wish it weren't the case. But I think just appreciating that that's part of what's going to happen for you as a woman in medicine. And I would say it doesn't really just affect women. It affects anyone who feels non-majority in whatever way. It might be because of your choice of specialty. It might be because of your life story. It might be because of your inner demons. It might be for any number of reasons. But I think for all of us to be intentional and expect that this dealing with the unconscious bias that comes to us because of our life story is a part of what we will do as physicians and physician leaders. And I would say one of the things that has been paradoxical for me in terms of my inner experience of this is that when I lost my husband now almost 10 years ago, it was paradoxically easier for me in medicine because I felt by being a good provider for my family, I was a good mother. And so it changed some of the distorting kind of gender-based, gender tensions that I had felt earlier in my career. It really helped me a lot. So for those of you who'd be interested, I have a few suggestions. First is I see many obstacles to people moving into leadership positions irrespective of your background. One is this idea that by being an idealist, that money is bad, that being allergic to money is somehow more virtuous. And what I would say about the data that you presented, what I always look for is how many women are in positions of power where they actually have a budget. So where they can control influences, control resources and influence people's destinies. And so one negative cognition I would encourage all of you to think about is not seeing working with resources or working in administration as kind of the work of the devil, but rather a way that you can actually create good. And really test this idea of idealism and resources. Second one is there's a view that assuming responsibility is a good thing, but that calling attention to oneself is a bad thing, that that's self-promoting. And I do think that you have to kind of get rid of this idea that it's self-serving, to have people learn why you are trustworthy, why you bring value to a situation, the perspective that you have, the skills that you have, and to try and reflect on how important it is for you to advance your strengths and to share your strengths with the people with whom you work. A next recommendation is look at your skill set. I've already emphasized the importance of resources. Everybody here should figure out how money works. Money works within medical institutions, within health systems. It's a great way to be more appreciative of what your boss is content with. It will help you advocate for yourself, and it also will help you invent better systems for the future. So learn how to work budgets. Second, learn how to speak in public settings. Really get your skill set around public speaking in place. It will be transformative, and it will allow you to have greater impact. Third is get some negotiation skills, and you can do that in these wonderful career development programs that Arthur highlighted, either ELAM or AAMC's offerings. There are often leadership offerings within institutions, and I think negotiation skills are fantastic. Just give you the very short version. To approach negotiation as a partnership is the solution. So if you can figure out what you can do to help together collaborate to accomplish something of importance, and if you can't get all of the pieces in place immediately, build a timeline or build another way that you can reconvene the conversation to make that happen. So negotiation skills. As was highlighted by one of our speakers, being a great doctor is really fundamental. You have to be a very fine doctor. And when you have any ability to build your research skills, I think that that's fantastic because it will allow you to have a different perspective. It will allow you to have greater credibility. And that leads me to another skill, which is learning how to leverage external power. Publications, grants, awards, serving on committees, these aren't things to only just put on your CV. They're extraordinary experiences and their value, but it also helps you demonstrate to people back home the ways in which you're contributing, the ways in which external authorities view the value of your work. So I think this is very, very important. When I was, my first job out, I was the first female hired in a set of 13 assistant professors. Everybody else got a computer in an office, and I did not. And so one of the ways in which I resolved that situation was just by getting a young investigator grant, just one. But that changed everything within weeks. And it wasn't for very much money, but it was learning how to leverage that to kind of raise the issue of having an office and having a computer. I'll also give you a tip on how to negotiate your salary. Look up the salaries, benchmark salaries in the AAMC books on salaries, and use the line I used when I was negotiating for my first chair. I said to my dean, I said, I am going to do a 99th percentile job, so if you pay me at the 75th percentile, it's a bargain. And so seriously, learning how to use external information to leverage, to demonstrate that you are a serious player and that you'll do serious good work. Last couple things are figure out your triggers, figure out the things that bother you. For me, especially at the beginning of my career, being highly visible was exhausting to me. And I then, over time, have come to become more accustomed to it. I hated taking risks. I'm not a risk taker by my nature at all. And when I applied to be the editor of a journal, a national journal, it was very, very difficult for me to deal with the scrutiny and the perhaps imagined criticism of that. And I remember I went to one of my mentors and I said, you know, I'm just not built for this. And he said, stop. If it's worth having, it's worth fighting for, don't withdraw. And I have to say I've been the editor of the journal now since 2002, and I'm ever grateful to that intervention at just that moment. So risk-taking is not my nature, so having people around who can help me think about how to assess the risks that I'm undertaking. I loved, Arthur, the point you made about how women don't necessarily apply for jobs where they don't yet feel qualified and they don't do the on-the-job training. I just thought that was a wonderful pearl of wisdom. So I want to encourage people to pay attention to that piece of advice, namely, take calculated risks. Don't be way out there, but with courage, step forward into these positions. So that leads me to the last couple of points. I think the most important thing is to figure out what you must do to be you. I'll say it again. Figure out the thing that you must do to be you. If you're by your nature meant to be a good doctor, then build your entire academic career around that moment of caring for patients. If you are meant deeply to be a doctor and a teacher, then build your career around that. If you can't go to sleep at night without reading about empirical evidence, generating empirical evidence, writing about and analyzing empirical evidence, you're going to have that research piece. But never give it up. And try to build your career around those things that you love most. Even if you sacrifice at certain points along your career path, try to build it around the things where if you fail to do it, you won't be you, because you will always feel joy and sustenance, which gets me to a point of your talk, which I'll comment in advance. I thought your talk was great, and I think joy could be good for everybody, just as a one-size-fits-all kind of thing. But many of us find joy if we align with the thing that gives us the most sense of purpose and meaning. And so some effort to try and identify those things, I think, is extraordinarily important in pushing back burnout and finding sustenance at the times that are hardest in our careers. And then investing in your relationships. I am sitting here with the privilege of sitting with Arthur and Mark and others because we have invested in these relationships over many years, and this will give you much joy as well. So then just very briefly, thank you, Arthur, for that. I'll just make a couple of comments about the other speeches, and then perhaps I could turn it over to Arthur. I loved, Neil, your talk about burnout. I thought it was really great. And Mark will tell you, he and I did early studies on medical student health care 20 years ago, maybe longer. 25 years ago, where the reviews were always split. It was seen as self-indulgent to be looking at the issue of physician well-being and physician distress. I remember one review in particular on a paper that we had written about stigma and access to care and barriers to care for medical students as patients, where we were kind of advancing this idea of thirst next to the fountain. Here you are right here, and paradoxically you can't access care. And people thought that it was inappropriate to view physicians and medical students as a special population. So it's immensely gratifying to see the attention to this and the fact that it's understood that there are vulnerabilities that come with being a physician that are important to study and know about. I want to compliment Nair, where are you? Maybe he's had to leave, about the wonderful mentorship work that he's been doing. Excellent outcomes as expressed in the wonderful accomplishments of the young people. And I love the humility and clarity with which he spoke about how we learn from everyone. We learn from our students. We learn from one another. I thought that was a wonderful gift of the talk. Dr. Carter's talk was great about handoffs and the transitions in care. And emphasizing the patient experience and how it then relates to better health outcomes. I loved your comments in the Q&A about confidence being related to foreknowledge of the patient. Don't walk into the room cold, and talk to one another so that coordinated care and support for the patient is more feasible. I thought Dr. Koshy's talk about radiation oncology and paradoxical disparities issues was really fascinating. In psychiatry, even the rich are an underserved population, so I often deal with the fact that people are suffering no matter what walk of life. But the profound issue of physician variation in practice and adherence to standards of care has huge health outcomes importance, so I hope you'll continue that really great work. Dr. Sharma on phase 1, where are you? Back there, thank you. Your work on informed consent is great, and it's fun to watch this next generation of phase 1 informed consent work done here at University of Chicago. I thought this issue of role modeling and education and understanding communication in these very sensitive moments was really a wonderful gift of your talk. I also liked your video analysis strategy, and I hope we'll see more of that in other studies. And Claire, second-year medical student, you're more poised than all of us put together. Amazing. You will do great things. It's very clear. And the fact that you just threw out the term moral angst in the middle of the conversation as if it were an understood term, deeply understood, was so University of Chicago. I loved it. So let me challenge all of you who presented today, though, to look at what the so what question is. Take it at a higher level. These are novel, important, small experiments. Could you do it on a bigger scale? If you have the outcomes that you have, what does it mean to the field of medicine and to the care of patients more broadly? And to go through the due diligent, hard exercise of asking, if the thing you studied was never studied, never appreciated, never seen, would it make a difference? And if so, what is the difference? What is the difference that you're making through the work that you're doing? And to try and articulate that. And certainly in every grant that you write, I want you to state that very explicitly. This must be understood because failure to understand this has this impact. And being a strong advocate for the work that you're doing by being able to answer that question. So thank you for the opportunity to make those remarks. Arthur, you're up.
I think I've spoken enough today. you know, I think the Bucksbaum Institute, as I began, is a kind of a unique and wonderful thing. I think Kay should feel very proud of everything that's been accomplished. University of Chicago, one of the great places to do it, as Laura points out, and those of us who worked and trained here are very proud of what we learned and what it did to us in terms of being great believers in this profession, and Laura painted that picture beautifully. You know, one thing I'll say, it sounds awful preachy, but there you are. You know, we are in the most wonderful profession. I mean, imagine being a lawyer. Sorry. And although we can make money, and I better be careful because I think Kay's late husband made a lot of money. But, you know, we are very, very privileged, and we should just every day think of how blessed we are to be able to do that. And then to do great things like being here under the auspices of this is like an added presence. So, you know, I'm a little older than all of you, but I wake up every day and I'm so happy that I'm able to do these kind of things. It's a true blessing. And one thing I think I'll leave you with, you know, one of the opportunities that runs through many of the talks, whether we're talking about each other in terms of burnout, whether we're talking about patients in surgical things lying on the table while they're awake. You know, if one is respectful of other human beings, irrespective of their role in life or their situation or their money or their culture, or it really, really makes a difference. And, you know, I hesitate to say it, but one of the most remarkable things I found when people when I stepped down from being the dean, somebody said, you know, you were the person who said hello to the cleaning staff or complimented this one or that one or the secretary. And I had never given it any thought. It was just natural. So you can spread a lot of joy and value around you with almost no effort, you know. And I think that's something in our position that we're able to do that we should be very cognizant of and very proud of. So at the end of all this, my wife will say, oh, he's really going to drive you all crazy. But anyway, this kind of atmosphere brings it out, and you should all feel very proud of being here and what's been accomplished. And it's always a privilege for Laura and I and Jordy to come.
Any other comments for our board members before we go to the final part of today? Well, I want to thank Dr. Roberts and Dr. Rubenstein for helping us get to this part in the Bucksbaum mission. Without our board, we wouldn't be able to accomplish many of the things that we are accomplishing. At this point, I would like to invite Jim Woodruff to the podium. We have our 5th year of the poetry contest winners to be announced. And Jim will announce our winners, and I think we'll hear the poems. Is that right? So,
that's right, Matt. Thank you, Matt. At this point, I'd like to invite our poetry contest winners to the front. Please take a seat over here at the panel table. And I'd also like to invite the audience to turn to the back of the program for today. You will find in the last few pages the poems that won our contest, including a little bit of information on our winners. So it is my distinct pleasure to introduce to you the winners of the 5th Annual Pritzker Poetry Contest. A little bit about the mission of this poetry contest. About 5 years ago, some of our students and a couple faculty chose to start this program. And the purpose of the program is to promote compassionate care by celebrating and exploring artistically the doctor-patient relationship. We are delighted this year to have had a large number of poems submitted from students, residents, faculty, and staff across campus. And I think it would be appropriate at this point to acknowledge the great poetry that came in and thank everybody who participated, because this is not just about the 4 poems that won the contest, but it's about a campus that is taking, I think, the doctor-patient relationship seriously. I'd like to give special thanks to a couple people Number one, I'd like to thank Dr. Rama Yeager, who helped found this poetry contest, and through his relationship with University Retina, has been funding the awards since the inception of this contest. He could not be here today, but I think he deserves a round of applause. The second person I'd like to thank is, of course, Dr. Siegler for inviting us to participate here at this prestigious symposium. This is a way for us to really put this poetry contest out there for everyone to enjoy. So now on to this year's winners. After all, you didn't come here to listen to me. You came to hear Pritzker poetry. Okay, so the poems were judged in two categories. One is the open poem format, which is poems up to 200 words long. And the second category is the 6-word poem, which sort of speaks for itself. So in the open poem category, first place is going to Leah Hofer for a poem entitled "To Be a Great Owner of a Butterfly." Leah will win $1,000 for this first place in the poetry competition. She is a second-year medical student here at Pritzker. She graduated from the Iowa State University of Science and Technology, and her current research focuses on global health. Leah, would you please read your poem?
Yeah, so like Dr. Woodruff mentioned, the title of this poem is "To Be a Great Owner of a Butterfly." It was something I came across, a child's words, thanking her teacher for teaching her multiplication, division, map skills, and how to be a great owner of a butterfly. Surprising because although great butterfly owners must learn to be patient and gentle and deeply kind to fragile creatures, unlike multiplication and division and map skills, no one measures these skills, and rarely do we notice so clearly when someone is teaching us these things. I think it may be the same in medicine. It is easy to measure whether or not we can calculate oncotic pressure, and we remember who taught us how to diagnose anemia. Yet, it is just as important to learn to be patient and gentle and deeply kind, and sometimes simultaneously strong and certain and confidence-inspiring. We start out fumbling, and along the way, careful. They're not always called teacher. Someone taught you how to be a great holder of hands, but also that there were times when someone might just need space. There was a person who told you to slow your heart and calm your mind as the hairs on your skin rose in anticipation of the unfolding crisis. You were not born knowing how to stay standing, all at once soft and strong and quiet on the worst day of someone else's life. Do you remember who showed you these things? Who was it that taught you how to be a great owner of a butterfly? Thank you.
Thank you, Leah, for that wonderful poem. The second place winner in the open poem category for a poem entitled, that is untitled, is Dr. Willard Sharp. He is an assistant professor in our section of emergency medicine, and he will receive $500 for this second place finish. Dr. Sharp is, as I said, an assistant professor in the section of emergency medicine. He received his MD and his PhD from the University of South Carolina School of Medicine and Biomedical Science, and his Doctor of Medicine, as I said, from that same institution. His residency training was completed at the University of Chicago, and he's arrived here at the University of Chicago to pursue a career as a physician scientist. Dr. Sharp, could you please present your poem?
Life has kicked me around and taught me a thing or two. For 60 years, I worked my bones, slowly growing old. Now all I have on me are words to say. Who would have foretold? Thoughts no one much seems to want to hear. My presence few could care. So pleased to see you now. Sit down and stay a while. So pleased to see you now. Stay and share your smile. Your compassion and gentle touch, a light of hope in the darkness. My body, worn and battered, is long beyond your technology's ability to save. And yet your caring is healing, giving hope beyond measure. You restore humanity, once though forever lost, giving my soul new hope for the future.
So we'll move on now to the 6-word category. So we have first place in this category, an untitled poem by Dr. Brian Smith. He will receive $500 for this first place finish in the 6-word category. Dr. Smith is currently a cardiovascular disease fellow here at the University of Chicago. Brian went to Harvard University for undergrad and then joined us here at the UC for medical school, so he's a Pritzker grad. He joined our internal medicine residency and is currently a cardiovascular disease fellow here. Brian, could you please present your poem?
Good afternoon, everyone. Hope you don't mind, I'm going to say a few more than 6 words. So I'm going to tell just a quick story about what inspired this poem. So I'm a 3rd-year fellow right now. When I was a first-year cardiology fellow, during one of my first weekends on call, I was in the ICU, and we accepted an outside hospital transfer. It was a young woman who had pulmonary hypertension and was in acute right heart failure. It was a new diagnosis, so she and her family were having a really difficult time with the diagnosis. And on transfer to us, we realized that there wasn't much that we'd be able to do for her. So her husband never left her bedside, and they had a couple of young kids at home, and he was absolutely devastated, but he stayed by her bedside the entire time. After she passed away, he was incredibly gracious, went around the whole ICU and thanked all of us for what we'd done for her. And right before he left, he turned to us and simply said, "You know what? I would still choose her again." Thank you.
Second place in the 6-word poem category was won by an untitled poem by Zaina Zayed, a Pritzker medical student. She'll be receiving $250 for her second place finish. Zaina is a member of the first-year class at Pritzker and is also a member of the medical scientist training program. Before coming to Pritzker, she was a student at Yale University. Zaina, could you please present your poem?
My poem is in a shared voice of both a physician and their patient. And it goes, "We will watch and wait together. It's a shared decision made." Thank you.
So at this point, I'd like to thank all of our winners, and once again, everybody who participated in this contest. Anticipate another year of great poetry next year, hopefully here at the Symposium. Before we close the poetry event, however, we have something special to the finish of the poetry contest presentation. To help us with this, I'd like to invite Michael Levine, who is Associate Vice President of Development for the University of Chicago, to the front.
Thanks, Jim. It's a great pleasure to be here. And the reason I am is because on Monday of this week, I happened to have lunch with Kay Bucksbaum, which is a very wonderful thing to do that I get to do from time to time. And when we were together, Kay said, "You know, it would really be nice if there was a poem about Mark Ziegler." So Monday night, I drafted a poem and I sent it to Kay on Tuesday morning. And Kay wrote back saying the poem is just what this doctor, referring to Kay, ordered. I never heard Kay referred to as a doctor before, but I liked it. And so then we contacted the appropriate people, and so I'm going to read this poem. The Unstoppable Mark Ziegler. An appendicitis cannot stop him. He has the energy of a young buck and is full of vinegar and vim, moving from patients to students with pluck, writing path-breaking papers for JAMA as he makes the world of medical ethics a science and an art without drama. that includes new forms of metrics that can measure the success of medicine that is practiced by physicians today with a new modern high-tech regimen of healthcare that requires a passionate way. Mark practices medicine with great care, starting with sincere communication that comforts the patient to a point where they have a most positive sensation, and will comply with doctor's instructions because they trust the thoughtful caregiver as they see his amazing deductions. They know that he always will deliver the best outcome and do it faster. And his students also trust his advice as they seek to emulate the master, to take their medical skills to new heights. And so it is not at all surprising that we call Siegler the Osler of his time, because he is the doctor uncompromising who is always working in his prime.
Well, that was more than a surprise, a shock. But thank you so much for that beautiful poem, and thank you to all our poetry winners. The poems were each of them moving and thoughtful, and I look forward to continuing this tradition of having the poems read at the Bucksbaum Institute annual event. I want to thank all of you for attending today. Throughout the afternoon, beginning with Dr. Rubenstein's magnificent keynote talk, we've heard a wonderful series of presentations by Dr. Rubenstein, by the Bucksbaum Institute scholars, and as you recall, many of them stayed with the focus on how we can improve our interactions with patients, patient care, patient outcomes. That's sort of the prevailing theme. And Laura, I loved your concluding remarks summarizing the afternoon. I want to thank all the presenters. I want to thank the leadership of the Bucksbaum Institute, Dr. Matt Sorrentino, and Angela Pace Moody, the center director. Angela, hi. And Tissa Williams, and our student interns. I also want to thank the now 132 Bucksbaum scholars for all the efforts they continue to put forth in their research and clinical efforts. I'll conclude by once again thanking Mrs. K. Bucksbaum and the Bucksbaum family for its continued support of the Institute. Without her trust and support, we obviously would not have been able to do what we've tried our best to do in the past 5 years. So with that, I look forward to seeing you all here next year, same time, same place. And thank you again for coming. Thanks.